Hello, everyone. Today I'm excited to be joined by Dr. Sarah Wakefield. She is an audiologist and an expert in the area of neuroaudiology. And today we'll be talking specifically about auditory processing and decreased sound tolerance in pediatric populations with her. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Welcome to Pediatric Pioneers, a MedBridge podcast where we conquer challenging topics for the pediatric therapist through conversations with pioneers who have blazed new trails in our practice. Our aim is to deliver actionable takeaways for practitioners like you. To receive continuing education credit for this episode and access bonus resources, be sure to check out medbridge.com. Hello, I'm your host, Nicole Quint, and I'm an occupational therapist with over 20 years of experience in practice and academia, specializing in pediatric practice and the improvement of occupational participation and performance through my expertise on executive function, visual perception, social-emotional learning, sleep, and sensory processing. It is my passion to support pediatric therapists like you so that you can best serve the families under your care with evidence-based practice solutions, easy-to-implement advocacy approaches, and new ways to lean into your skills within the challenging pediatric landscape. And by the way, we brought Dr. Wakefield in because you asked for more speech therapists, more audiologists. And so we are listening to you, and we're really excited to have Dr. Wakefield here with us. So welcome, Sarah.
Thank you. Thank you, Nicole. I'm grateful to be here. Um, I'm happy that I could contribute in some way to give you this content.
Well, we're excited to have you. So, could you get us started by sharing a little bit more about yourself and how you became involved with auditory processing, decreased sound tolerance in pediatric populations?
Sure. Well, currently I'm an associate professor and clinic director of the audiology clinic at Nova Southeastern University, where I teach both clinically and didactically in the classroom. Um, but really, my interest started during undergrad. In my psychology and anatomy courses, I just became fascinated in the brain and how we process information. But I think the defining moment for me was when I observed an audiologist doing an auditory processing evaluation, and I was like, yes, this is what I want to do. This is what I want to understand better. And so, fast forward, I had completed my doctoral coursework, started my externship, and this was at a clinic that specialized in auditory processing disorders. So, that's pretty much the only patient that I was seeing, sprinkled in with a few older hearing aid evals and things like that, but primarily auditory processing, which is pretty rare. And over my time there, the clinic actually evolved into an interdisciplinary clinic. And we were primarily servicing children who had auditory processing disorders, sensory processing disorders, individuals on the autism spectrum, or people with ADHD. But during this time, I had the amazing opportunity of working with occupational therapists,
Mhm.
speech and language pathologists. We had a psychologist who was in the same clinic, and we would all come together, each do our individual evaluations, but then meet to talk about what was the plan? What was therapy going to look like? And in some cases, we were actually co treating. I mean, I remember in my externship, there would be a kid swinging in a swing, and I would be working on auditory memory exercises, which
Mhm.
as an audiologist, I never really got to experience that until I was in this type of setting. This is where I really learned that OTs did much more than pencil grips and handwriting, right? There was so much more going on there. And I learned this functional view of patients. Occupational therapists really taught me that it's not just the hearing and the diagnostic information. It's the functional output. How is this person functioning in real life? And that was just such a valuable thing for me to learn. And during this experience, I really started to understand that while the ear was my window to the brain, it was telling me so much more about other parts, other systems of the brain. Attention, working memory, sensory and emotional regulation, all of these things I was able to assess by looking at their auditory system. So in 2012, I joined Nova Southeastern University and really wanted to help spread my love of neuroaudiology onto future audiologists. And this is kind of how I came to getting interested in sound tolerance. So I was researching, putting together my lectures, and I came across information by Augie Moeller out of UT Dallas. He does a lot of work with sensory systems.
Mhm.
And so he was talking about the classical and non classical auditory systems, multisensory integration, auditory, somatosensory, vision. And one study that really struck me of his, he was looking at the impact of somatosensory input on perceived change in loudness. So in the study, they were measuring stimulation of the median nerve and they were looking at does the individual perceive a growth or change in loudness or a decrease in loudness? And what they found was that this perceived change was really only present in children, with the greatest change occurring between 7 and 8 years of age and diminishing as they got older. And this is really what sparked my interest of sound sensitivity, tinnitus, and kind of that interconnection of other senses with sound. So here I am today, seeing patients in the clinic, primarily in the area of APD, tinnitus, and decreased sound tolerance.
That is so interesting. And I think about when you were talking about the interdisciplinary team that you were working with the SLP and the OT and everything. And I just think that's such a great way to practice with some of the populations that we've been focusing on this year that are in that neurodiverse, kind of field. And I just don't think we do that enough. So I think it's really exciting to have you here and talk about these things because I know there's a lot of OTs and SLPs that I speak with that feel that these are kind of under recognized or under discussed topics that are really kind of maybe holding some kids back, whether they're in school or whatever they're trying to do, and they're going unnoticed. And everything ends up being called a behavior. So I think shedding some light on that today is really going to be important. So on that note, kind of said a little bit about it, but why do you think it's so important to discuss auditory processing and sound tolerance disorders for pediatric clients?
Sure. Sound is just so central to our lives, right? Listening and communication, it's what connects us to others. It's part of our culture. It's central in the learning process. When a
Mhm.
child is struggling to process or regulate sound, it truly impacts their daily function, right? And as you said, behaviors often get labeled as inattention or non-compliant or this child is anxious, right? When really it just might be related to how they're processing auditory information. And I agree, so many times these kids don't necessarily get the help that they need, maybe because we're not working together as a team. One person's doing their evaluation and another person's doing theirs, and we're not really meeting to talk about how we can all serve this child together. So both auditory processing, which I'll probably refer to as APD as I go along here, and then decreased sound tolerance. And when I talk about decreased sound tolerance, I'm talking about hyperacusis, misophonia, noise sensitivity, phonophobia. I'll get a little bit deeper into exactly what the definitions are a little bit later, but these are all conditions that are comorbid with other diagnoses. We see them frequently in children with ADHD, dyslexia, sensory processing disorders. And it just makes a multidisciplinary approach so important when we're working with
Mhm.
these populations. It is so rare that I see a child who only has an auditory processing disorder or only has decreased sound tolerance.
Right.
And that's why I'm frequently referring out or receiving referrals back and working with other professionals.
Mhm. Yeah, and it's so I think about it too, one of the frustrations is that it's often not included in a lot of the assessment tools that we use, right? And so, again, it's not necessarily being highlighted. If we're working in silos, we all kinda know what happens. So, as a result, knowing that it's easy for these kids to maybe fly under the radar or the focus gets put into a different area and maybe we miss the DST or the APD, what questions should we be asking as practitioners? Is there anything that we should be questioning in the situation about our day-to-day process or how we're working with these kids?
I think it's, just being mindful about how your client is processing auditory information. Do
Mhm.
you see evidence of auditory processing? Are they frequently saying, huh, or what? Or if you give them multi step directions, do they have difficulty following them? Uh, do they tend to mishear things? So if you say, sit and they hear fit, or you say time and they're hearing dime, right? Or even understanding the meaning of what somebody is saying. If I
Mhm.
say, "Oh, that's great," or "Oh, that's great," same exact words, two very different messages. And oftentimes that's what we'll see in kids with auditory processing is that they're struggling with these different aspects. So if you're seeing those things popping up or parents are reporting them, it may be beneficial to make a referral. Um, with decreased sound tolerance, I think it's a little bit more obvious, right? These kids have a lot of behaviors that come along with that. Are they triggered by certain sounds? How does it impact them? Um, when we get into decreased sound tolerance, it really becomes what type of sound sensitivity are they experiencing? And I think that's the value that an audiologist can provide is kind of help guiding us to figure out, okay, what exactly is going on here and what is the best way to kind of move forward with treatment. So if you suspect that they're struggling with any of these things, refer them out. I will tell you that not every audiologist specializes in auditory processing or decreased sound tolerance. So it's probably a good idea to get an idea of who is in your community and kind of reaching out and seeing are they experienced in this area? And maybe if they're not, are they interested? Maybe it's something that they could develop into their practice.
Mhm. And I always recommend people, is there a program in your area at the university or the college and starting to get some relationships because somebody there probably does have pediatric experience because they
Mhm.
have to teach it, right? So, that can be helpful as well. So, on that note, of kind of how do we think about what we're doing with these kids, and you said that DST is obviously gonna be more noticeable than maybe APD. What does the recent research tell us, so that we can really understand this grounded in evidence? Because I think that's really important. Because some people might be listening and kind of saying, "I kind of really know this information pretty well," but there's gonna be others that are gonna say, "I kinda have an idea, but I need to know a little bit more."
Sure. I'll get started with auditory processing. So, just a quick kind of definition. Auditory processing is a clinical condition. It's characterized by difficulties in the neural processing of auditory information when hearing is normal, right?
Mhm.
So, we're looking at individuals where hearing is normal, everything is moving through the peripheral system okay. It's just somewhere along the line in the central auditory nervous system and connecting with other systems that we have some sort of breakdown. Um, so that's actually a really important point because auditory processing cannot be completed if there is a hearing loss, right?
Mm.
Or if there is a little bit of a hearing loss, sometimes that's going to limit which tests that we can do. And even something as small as having congestion in your ears will make me say, I don't know. I'm not going to assess this kid today because I don't want to take them on a day when their ears are all congested. You know, how when you might feel after you descend on a plane and you feel like you need to pop your ears, right? That feeling. I don't want to take that child and put them through a 2-hour test battery and say, oh, this could be due to middle ear congestion. So making sure that you've ruled out any type of hearing loss or chronic middle ear pathology, that's important before really getting started with an auditory processing evaluation. And in our clinic, we will ask those questions to kind of screen out. So if there are any concerns about recurrent middle ear infections or hearing loss, we'll see you for just a hearing test first and get all of that information. And then we'll schedule you for the full auditory processing evaluation. So
Mm.
every auditory processing evaluation should start with that.
Uh-huh.
Um, and so the reason why we can't test on individuals with hearing loss is that we don't have good normative data, especially in a pediatric population on individuals with hearing loss. There's already such a wide range of what is normal, typical development in these kids that layering a hearing loss on top of that just it doesn't make sense to do the testing.
Mm. How many kids are diagnosed with APD, roughly?
So prevalence for APD is probably it's somewhere around 0.2 to 5%.
Oh.
So we've quite a window there. I
Mhm.
think that comes down to having a standard test battery with APD. Um, there isn't a universal kind of agreed upon, these are the tests that we're going to do. This is what you need to make that diagnosis of auditory processing. So that's something where we still have some work as audiologists to really come together and kind of get better normative data and get better guidelines as to that diagnosis. Um, one other thing that's important to note is that children really should be 7 years of age before we
Mhm.
make that formal diagnosis. I frequently will get referrals for younger kids because you guys are picking up on something's not right. This kid is
Mm.
not processing auditory information correctly. And it's not that that doesn't exist, it's just my normative data isn't great until 7 years of age because there's just such a wide range of what is normal. So
Mm.
I will see kids as young as 5, but I won't make a formal diagnosis until 7 years of age. In fact, I just had a little guy come through my clinic who I agreed to see this week, and he was 5, but he arrived with a report from the speech and language pathologist that said he had a language age of 3. Well, I
Mm.
can't evaluate that child because he doesn't have a language age of 5. And then on top of that, he also had some negative middle ear pressure and other things going on. So in that case, it was valuable because I said, hey, this might actually be the issue with his inconsistent
Mhm.
listening, right? He's not hearing because maybe one day he's stuffy and congested and the next day he's not. So
Mm.
um, it can be valuable to make that referral. I think maybe not referring for a full auditory processing evaluation there, maybe more a hearing evaluation and a screening at that point might be more valuable.
Yeah, that makes sense. And I know earlier you said there's a significant overlap with diagnoses such as ADHD, dyslexia, learning disabilities, I would imagine as well. Are there any other diagnoses we should be looking out for that there's a significant overlap with?
Uh, I think you hit a lot of them. Yes. And really when we look at that overlap, about 60% of individuals who present with auditory processing are going to present with other neurodevelopmental conditions like
Okay.
ADHD, dyslexia, um, language disorders are another big one. And it's just because it's hard for us to tease out, is it the attention or is it the
Mhm.
auditory component of it? If you're not hearing things clearly, you're going to tune out. Or is it that, you're tuning out that you're not hearing them clearly? So it is a bit of a chicken and an egg type of situation. And I think that that's why we have so much debate surrounding auditory
Mm.
processing and kind of, you know, is this an attention deficit, or is this auditory processing, or is this a language processing delay? And we do see uh, a lot of that debate even going on to today,
Mhm.
right? From my perspective, I don't see auditory processing as purely bottom up or top down, right? I see
Right.
it more as that dynamic interaction between both of the systems, right? It's effective listening requires not only the sound being efficiently transmitted, but the attention to be engaged, our working memory to be intact, and our
Mhm.
ability to comprehend language needs to be there. So it's that interconnectedness that kind of helps us to be able to process our whole environment. And beyond that, you can't process things as just auditory. You have visual information coming in. You're sitting in a chair, right? There's so many other things that are going
Mhm.
on.
Yeah. And that, and like I know you were saying if they have, some kind of congestion or history of a pattern of congestion or middle ear involvement, that's something to be aware of as well.
Yes,
Yeah.
definitely. For both auditory processing and decreased sound tolerance, it's something that's important to pay attention to.
Mhm.
There is research out there that shows that children who have chronic middle ear pathologies, they are going to be behind in
Mm,
auditory development. Now, they will catch up, and I think that's where you get that window of what's normal, right? A
mhm,
lot of kids experience frequent or recurrent ear infections when they're younger, which is when they're learning about speech and language. And
mhm,
the auditory system is part of that. So if they're hearing one way one day and another way the next day, it's going to impact kind of the representation of sound. Right. And so a lot of kids, what you'll find is that if auditory is not stable, is inconsistent, they're going to move into being a more visual learner or a more tactile learner. And it's just part of shaping how we learn and who we are, right?
mhm. Right. So I know you have told me before there's really 4 approaches that the evidence supports in terms of how we will intervene to support kids with an APD diagnosis.
Sure. Yeah. So, when we look at kind of, you mean like like the
The
4 different
environmental modifications
Oh,
and
got
things
you.
like
Okay.
that, yeah.
Sorry. Sure. No, I'm confused because I normally refer to it as three-pronged, but I see where you're getting the fourth one from. So, environmental modifications for sure.
Mhm.
Those preferential seating, reducing background noise. You can even have the teacher wear an FM system, right? So where
Right.
they're wearing a little microphone, and either the kids will have a little device that they'll be wearing ear level,
Mhm.
or or you can have something that's on the desktop or even in the sound field in the classroom. There are even some kids and research now to support fitting them with a low amplification hearing aid.
Mm.
I did this a while back with a little girl. And I'll never forget it. I'm like, this isn't going to work, right? We're putting a hearing aid on her. She's going to be so bothered by this, and man, she loved that hearing aid. As soon as it would break, she would be in and be like, "I need this back." It was really helping her to be able to stay focused and engaged in the classroom.
Mhm.
Um, the other is direct interventions, and that's, I think, really where we get into this interdisciplinary or multidisciplinary interaction. Um, a lot of my recommendations will refer back to a speech and language pathologist to work on phonological training, right? Or maybe linking back up with a psychologist to look at auditory working memory exercises, or referring to an occupational therapist
Mhm.
if I'm seeing a kid that I have concerns about other sensory processing elements that are going on with them. So
Mhm.
that's definitely something that I frequently will make. Oh, vision therapy is another big one.
Mm.
I frequently will refer to them to do a functional vision assessment because the kids that I'm getting for auditory processing are typically coming in for reading and reading comprehension, and vision is definitely a big part of that.
Right.
Um, we do have online programs now for direct intervention, particularly when we're looking at dichotic. And dichotic is meaning two different sounds coming in at the exact
Mm.
same time. So there's certain test measures that we look at the efficiency of the brain in doing this. And we have a lot of online programs now that allow us to do this dichotic training, which is nice because
Mm.
before it required them to come into the office, multiple times a week. It's taking up booth space. And so it makes it more accessible for the parents and the kids
Mhm.
to complete.
Yeah,
Um,
I was wondering if you had anything that you could do telehealth wise, so that's really interesting.
yeah,
Mm.
yeah, that's probably about the closest thing that we have with
Mhm,
telehealth with auditory processing. Um, I've run through, several kids with that program.
mhm.
I've used several different ones. There's one called CapDots and one called Acoustic Pioneer that I've used, and I really like it. It definitely is. I think it's funny because when you think of audiologists, we probably went into audiology and not speech and language pathology because of the week to week therapy. So when you're bringing a child back in every week, a lot of audiologists are like, yeah, I don't really know that that's for me. So I think having the ability to make that online is really nice, and then we'll see them back, after they've completed a large chunk of that to reevaluate and assess and make sure that we're seeing those changes. So
Yeah.
that's been really great. Compensatory strategies are also great. Giving them a classroom buddy, pre-teaching or reviewing vocabulary is important. Teaching them that it's okay to ask for repetition and when it might be best to do that. All of those things are kind of part of that process.
Yeah, and that's where I see the magic happening between audiologists and OTs and OTAs, quite honestly, in the school system, because if we understand what's going on with the kid from, what you've seen, and then you're giving these compensatory strategies, we can then observe them in the classroom to see how they're using them, how they're advocating for what they need, working with the teacher and making sure that then they can engage in their educational occupations and social occupations effectively. So I love that kind of, interdisciplinary work, which is great. So we've talked about the APD part, which is so fascinating to me, and I always think about when I was in working with students and kids and how often schools would kind of, and I'm just saying schools, people in the schools, whoever, would kind of dismiss auditory processing. And, I'm really hoping that maybe we can start making some changes as people become a little bit more educated on that. But I want to talk about the decreased sound tolerance because I think that's a really interesting topic that I think not as many pediatric therapists are as, kind of know as much about. So, can you share a little bit about that?
Sure, I'm happy to. I agree. I think it's something that is relatively new for all of us.
Mhm.
Audiologists, uh, we have learned more about it, I think, through tinnitus and working with tinnitus patients, and have really seen and been working with these patients because there's such a high comorbidity between hyperacusis and tinnitus that we really have seen a lot of patients. And with TikTok and Instagram, all of the videos for misophonia and all of these things, I see a lot of patients coming in and they're self-diagnosing. I have this. This is something that I'm experiencing.
Mhm.
And so I think it is something that is receiving a lot more attention. And we're seeing a lot more people who are aware that they do have decreased sound tolerance or difficulty tolerating sounds in different environments. So, sure. Let me start off by just going through the different types of decreased sound tolerance.
Okay.
The first one that I wanna touch upon, because it really is kind of the catch-all, I think if you look at, the ICD-10, that's the only one we have a code for, which is hyperacusis.
Okay.
Anything else, I typically code for, abnormal auditory perception, right? So,
Mm.
the umbrella term that you will hear in the medical field is generally going to be hyperacusis, and when we talk about hyperacusis, it's a discomfort or pain in response to a what somebody calls loud, right? Loud sound that other
Mhm.
people find comfortable. So it's really not a loud sound, but the perception to that individual is that it was loud. And the key here is that it's causing discomfort or pain. Um, the second category is misophonia, and this was a term that was first coined by Paul Jastreboff. So he actually created an entire, it's called tinnitus retraining therapy. And so he was the first person to really put a name to this. And so misophonia is a strong dislike of a certain sound that causes an emotional or behavioral reaction. And it's important to note that individuals with misophonia may also have a reaction to the visual component as well. So you can take away the auditory component and they're still looking at that person chewing and going, oh my gosh, I'm going out of my mind having to watch this. I should bring in a fun fact here. My husband has misophonia and but we still have one pug. And if anybody knows anything about pugs, they love to lick. And my husband, even the sight of the one pug getting ready to lick would be like, oh my gosh, please stop it. And that's his misophonia reaction to that stimulus. So that's misophonia. The next one is noise sensitivity. And noise sensitivity refers to increased reactivity to sound that may include more general discomfort or like an annoyance or feeling overwhelmed when they're in a noisy or busy environment. And this is regardless of loudness level as well. Um, this is not linked to intensity or perceived loudness. It's just that these individuals are more comfortable in quiet.
Okay.
Mhm.
Interesting.
Um, yeah, and the last one is phonophobia, which really phonophobia, I think, kind of results from these other conditions. If you have hyperacusis, you may become fearful of of loud sounds in your
Mhm.
environment, right? And or you may become fearful of somebody making a particular sound or going out to dinner with that individual. So with phonophobia, it's an emotional response or fear that a sound may occur and that it will result in increased anxiety, discomfort, or pain.
Mhm. The first time I saw someone with hyperacusis, it was a training video on an assessment tool.
Mm.
And because it was a training video, it was easy to think like, is this acting or is this real? And watching this young girl have such an extreme reaction to, like, dogs barking, I think they had, like, a boat and then, like, maybe the police siren or the fire siren to where she was so distressed. It was very interesting, and it was easy to think, "Is this acting? Are they just trying to make sure we understand how to do the test?" And then come to find out she had hyperacusis, and it was just very, interesting to watch because, to me, right away, I start thinking, like, how do you even function in society with this? And so now appreciating that phonophobia can come from that makes complete sense.
Yes, yeah.
Yeah.
A lot of these patients will start to withdraw.
Mhm.
Decreased sound sensitivity conditions are always heartbreaking to work with because of the functional limitations. You know, with misophonia, a lot of times the person who is most bothersome to you is, or for these kids is a parent. It's their mom.
Mhm.
And they
Yeah.
don't want to feel this way. They don't want
Right.
this intense emotional reaction, but it's happening and they don't have any control over it. So
Right.
it's a lot going on and a lot to unpack with these kids.
Yeah, and I can think of all the noises at school too that can cause some of this stress. So, yeah, it was really upsetting to watch this reaction. So, I'm really glad that we're addressing this because I think that it's exciting to think that now people can feel more comfortable addressing it. So tell us a little bit about each type of DST. I know you kind of went into it already, but what are some important things that we need to know about them?
Sure. Yep. So when we uh, looking at different types and interventions, it's kind of important to know which one they're presenting with, right? Because we might have different ways of treating and working with it. I want to back up a little bit because I want to talk a little bit about auditory gain before I get into those interventions because um, it has a lot to do with how our brain is going to calibrate for these sounds in our
Mhm.
environment. So, I'll start with just a general overview of the central auditory nervous system, or the CAN. So, we know sound is being picked up by the inner ear, the cochlea, going along the auditory nerve. It's going to travel to the cochlear nucleus, right, which is our first level where we start to get that multisensory interaction going on, up to the level of the superior olivary complex. This is where we're getting our first level of binaural input, localization to sound. Lateral lemniscus is our timing and amplitude modulations. Inferior colliculus is spatial cues, multisensory integration, startle reflex. And then medial geniculate body is going to go more into refined auditory and modulation of attention. And then finally, the information's going to your primary auditory cortex. And so this kind of leads me back to the high root and low root that I was talking about from Augie
Mhm.
Moeller earlier. And, you can think of the high root as the root I just described, right? It's the path to the primary auditory cortex. Now, the low root is going to be faster delivery. It's going to kind of shoot off at the level of the inferior colliculus and medial geniculate body into the limbic system, specifically into the amygdala. So think
Mhm.
low root as the brain's kind of fast alarm, right, responding to this. And it happens automatically. And it's oftentimes an emotional type reaction without us thinking. Again, think startle reflex, fight or flight. Um, the high root is going to be the kind of slower thinking, processing, and kind of what is the meaning behind that sound experience or kind of attention with it. So these are both important to decrease sound tolerance, right? Because it helps us to better
Mhm.
understand why we're having these intense emotional reactions connected to this. So the low root is going to kind of create that immediate body response, and the high root then reinforces these behaviors with the meaning of it, the fear of it, right? So
Mhm.
both are kind of keeping this individual in this loop. Um, so the concept that I really want to get to with this is auditory gain. And I think OTs are generally familiar with this, looking at sensory adaptation or sensory modulation. And
Mhm.
auditory gain is really going to fit into this category. You can kind of think of it as that internal volume control in the auditory system, and it's based on our external environment. So if things are soft, your auditory gain is going to increase. If you're in a really loud environment, your auditory gain is going to decrease. So your volume control is doing a little bit of work. Internal volume control is doing a little work. And I think an important study to really point out here was by Formby in 2003. And it looked at exposure to either exposure to or avoidance of sound and how it influences that central gain. So, in this study, participants were either wearing earplugs or wearing a sound generator in their ear. So, earplugs, sound reduction, sensory
Mhm.
deprivation. Sound generators were sound enrichment in that environment. So, these different sound environments either resulted in decreased sound tolerance for the individuals who are wearing earplugs all the time. They became more responsive to sound, their tolerance went down. And the individuals who
Mhm.
were wearing the sound generator actually had an increase in their loudness tolerance, where they were able to tolerate louder sounds.
So
So,
interesting.
and this is something that's been replicated in multiple studies, and I think is very important as we start to talk about treatment and management of these
Mhm.
conditions, because oftentimes we get into a situation where we're like, okay, they're not doing well with sound, let's pull them out of these environments, or let's put headphones or earphones on when they're exposed to these sounds. And
Mhm.
while those are great things to do in the moment when you need to be in this environment, they really are not helping to move past this decreased sound tolerance that the individual is experiencing. And so we actually want to go the opposite direction and enrich their sound environment. So, when we look at different interventions for hyperacusis, definitely behavioral therapy is central, right? Because we need to kind of talk about some of these fears and things that are happening surrounding the sound, but also graded sound desensitization, right? So, Jasterboff, the individual who created TRT, talks about auditory toughening. You're
Mm,
introducing sound in a safe way. It's not like we're saying, "Oh, you have to sit here and listen to this sound." The individual's in control of what they're listening to and the volume that they're listening to, and just slowly, gradually enriching their sound environment and inviting more sound in.
mhm,
That's definitely something that can be very positive. So when you're thinking of working with these kids, really think about helping them to introduce just a background noise into their
mhm,
environment. And you can do it on like a tabletop or even having them wear headphones where they are listening to a sound. One thing I might think of is, if you have a child with ADHD and they're very distracted when taking a test, rather than just putting headphones on with no sound whatsoever, maybe putting headphones on that are playing something with like a white noise,
mhm.
that
Right.
isn't silence, but isn't distracting to them.
Mhm.
Um,
Yeah.
Misophonia and noise sensitivity evidence really supports cognitive behavioral therapy with
Okay.
this group of individuals. Um, of course, it's very important that we are sensitive to not just putting people into these environments and stressing them out. I have read articles where people who have these conditions are like, "Hey, it wasn't so nice that you took me and you know, give me
Right.
exposure therapy to this." So just making sure that it's happening in a way that is mindful of the person who's experiencing it. And then also, TRT has a protocol in which you are pairing positive sounds with
Mm,
um, with the trigger sound that the
right.
individual might be very reactive to.
And can you explain what TRT is so
Sure,
make sure everybody knows?
tinnitus retraining therapy. So I know it's saying tinnitus in it, but it also includes decreased sound tolerance, and there is a whole misophonia protocol in there. Unfortunately, I think Dr. Jastreboff stopped doing the course. I think an audiologist is looking at revamping it. He has retired. Uh, if anybody's interested in getting the training in this area, I do think that somebody else is going to revamp it and kind of open it up again.
That would be
But
good.
it was very helpful for me in learning how can I deal with these different decreased sound tolerance conditions. Um, Another major thing in kids with misophonia or noise sensitivity is referring out to an occupational therapist. A lot of
Mhm.
times, these kids have sensory processing disorders and they need that support to help them functionally deal with this in their different environments at home
Mhm.
and then also at school.
Yeah, and I can imagine, we already kind of went over like a lot of the kids that would be prone to this that we need to be sensitive to, whether, they're all on the neurodiverse spectrum or anxiety disorders, things like that. The histories of the chronic, having, ear infections, we know that that's something to look for. Um, but also if they're complaining. But I'm also thinking about all the kids that we see that struggle in noisy environments. They are overwhelmed by sound. They get fatigued from l- listening tasks, which would be school,
Yeah.
right? Or they're in a group environment, or you see that they're relying more on the visual cues. So these are the kids that we know are vulnerable. So now that we know a little bit more about the research, and some of that I think was probably a little bit eye or ear opening to our listeners because you go back and you think, what are some of the classic treatments? Quiet room, right? Uh, let's put some headphones on. I remember celebrating when headphones became cool again because it's like, oh, great. Now we can help you, transition because it's so loud and not realizing because, maybe this, we know it's 17 years before research gets to practice that maybe we were doing the opposite of what we were trying to do. So now that we know the research, how do you see this translating into practice areas? Like you said, if you're referring to an occupational therapist or an SLP, what could we do to work with these kids knowing what they're up against?
Yeah, I mean, I think just helping them to structure their day and kind of prepare them for different situations that might cause discomfort with sound, right? How are they going to deal with it? What do they feel comfortable with? Things like cafeteria, fire
Mhm,
drills, those types of things are always problematic. Giving them the tools that they need to be able to get through that. I think that that's so important. From a treatment management standpoint, I think introducing some sort of sound therapy is a great idea. And now that's something maybe you feel comfortable doing, maybe not. That's where finding an audiologist might be helpful
mhm,
so that they can kind of work in the mix to introduce the sound therapy while the occupational therapist is really helping uh, to help them manage their day, right? And
mhm,
be able to functionally participate in what they need to. Um, Now, certainly from a speech and language perspective, auditory processing can definitely be tied in there. There's a lot of different, I think I talked about before, phonemic awareness that can be
mhm.
worked on with audiologists. Additionally, auditory memory might be worked on, or not audiologist, speech and language pathologist, sorry. So they can work on that, auditory memory. Um, yeah, I mean, all of these things we can work together as a group and kind of come up with a plan of what would work best for that child because ultimately every child is different. There's not like a one size
Mhm.
fits all treatment, and that's what I'll tell parents, especially after I do an auditory processing evaluation. I'm like, "What are you currently doing?" Because I don't need to add one more thing to your plate. I need to make sure that this child can still be a child and have these natural experiences for learning, not all of these box therapy type sessions. I think it's
Mhm.
important to have those experiences that are a little bit more natural as well.
Yeah. And so, if I have a kid coming and they need to be evaluated, is there anything that I could add in if I had concerns, maybe a screening tool or something like that that would be helpful?
Sure. Yeah. I mean, there was one actually just published, which is the Misophonia and Hyperacusis questionnaire. It's the first to really combine both misophonia and hyperacusis together for kids. And it was developed by occupational therapists. I know,
Yay!
right? It's great. I love it. It is actually normed on children with and without autism, ages 6 to
Oh,
17 years of age.
wonderful.
So that's really cool. Um, we also have the Misophonia assessment questionnaire that's out there. So those are both two things that you could use with decreased sound tolerance. And then for APD, I use the CHAP. It's older, but I like it.
Uh-huh.
It's the Children's Hearing and Auditory Processing. It just works. But I think these are really important components, especially for something like decreased sound tolerance. There's
Mhm.
not really much that I can do from an audiological perspective when I'm evaluating it, right?
Mhm.
I'm really going to be using structured interviews and questionnaires to get an idea of what decreased sound tolerance the patient is experiencing. And then from there, I'm going to engage in some sort of educational counseling. And that, for a lot of patients, is what they need. They need that educational counseling to help them better understand, why is this happening to me? And then it helps them to kind of work through. And that's really the foundation there with the management.
Mhm.
Um,
That makes sense, definitely.
yeah.
Mhm. When I thinking about, you know, the environment is so important in this. So identifying those triggers and everything so that we understand maybe why they aren't participating or why they're having the emotional or behavioral responses that they're having seems really, really important. And then what are some of your thoughts on like auditory motor integration and how we can emphasize that?
Yeah, I think it's so important to look at those things, especially in our younger kids, right?
Mhm.
As you look at typical development, you can start to see, is a child sitting up when they're listening? Are they turning and localizing to sounds? These early developmental milestones really lead into those more functional the more functional aspects of hearing, integrating what's coming in from our right and left ears, being able to start to filter out background noise. So really looking at um, how these senses are starting to integrate together. When you hear a sound, you're going to pick it up. You're going to be able to tell which side it's coming from. You may have your eyes go first and then your body turn. So there's such
Mm,
integration happening between all of our senses. So I think that it's important that we pay attention to these things early on so that we start to pick up on things that maybe aren't typical in development and give suggestions as to how we can start to improve that through functional learning experiences.
okay. Yeah. So I'm imagining right now there's therapists sitting here going, what do I do in a session? Because, we love to treat.
Yes.
So I'm sure there's lots of things they can do that they already know, like visual supports, movement breaks before they have to listen. Those are sensory regulation strategies. I know that they're self-advocacy training, but let's get into the environmental modifications, the use of headphones, pros
Okay.
and cons, because to me, I think I wanna be really clear on this because there's probably been one way a lot of people have been working, and now we know there's a better way.
Yeah, I think it's not something that you say, "I'm never going to use this," right?
Mhm.
There are still going to be situations, like, if that child is very reactive when they go into a gymnasium for, some sort of special event, wear them in that situation. Allow them to have that experience there. That's an okay situation. But if we're using it on a day-to-day in a regular classroom situation, that might not be the best way. Maybe start to think about, like I said earlier, maybe headphones that play sound in them. So we're
Mm,
not completely blocking out sound. We're still introducing sound. And you want to be mindful about the sound that you're choosing. If the sound that you've selected is obviously causing distress to the individual, it's not the right sound. We all have different preferences, right? Somebody might like a white noise, somebody else might like a pink noise. So it just comes down to personal preference, and it's okay. Their research does not show that there's one sound that's superior to another sound.
Oh, okay, well, that's good to know. Yeah, because everybody likes something different. I like Pink Floyd, so there you go.
You know what? You could listen to Pink Floyd. That's
I
perfect.
did as
I
a
when
kid.
you get into the TRT training with misophonia, one of the things might be to listen to music that evokes that positive emotion for you, because music is so personal to people and
Oh, yeah.
does evoke different emotions. You can think of maybe somebody might hear their wedding song or something like that and have all of those emotions come flooding back to them. So we can use these positive sounds and link them to these trigger sounds to kind of help extinguish that between the two.
Yeah. It's funny, I bring the Pink Floyd thing up because a lot of people that have taken my sleep courses know that that was sort of my thing that helped me sleep when I was a kid.
Really?
So, yes, yes, 100%. And it's so interesting, like, thinking about that there hasn't been one type of noise that's been shown to be superior. So I love that it really gets to be this client-centered opportunity where they get to pick the one that works for them, and I love that's so empowering to a kid, I can imagine, who has these, DST issues, and sound is so stressful. To find one that works for them, I can imagine it could be very empowering. So that makes me excited to think about. And you talked a little bit about, the sound exposure for hyperacusis, the graded sound exposure. How do you see that maybe playing out in an occupational therapy or speech language pathology session?
I think typically, when we deliver it as audiologists, it is ear level. We may actually have the individual wearing a hearing aid or a sound generator device. We have so many things these days on our phone, right? You can download an app and you have access to so many different types of sounds. I think you could use an AirPod or use a Bluetooth headphone. And so it's really about finding what is comfortable for that patient. You never are turning up the volume to a point where it's causing
Mm,
distress. Or if you're in a learning environment, right? If they're at school or they're working with a speech and language pathologist, you don't want it to be distracting. You want
Mhm.
it to really be there in the background. Um, so, with the graded desensitization, really what you're doing is slowly turning up the volume as it becomes comfortable for them. So it is dependent on the patient. This might
Mhm.
be a little bit harder with younger kids. It might be
Yeah.
something that you have to do more in an open environment rather than ear level.
Mhm.
My suggestions might be to play something at night, rather than having it be quiet at night, putting on some kind of sleep music, Pink Floyd
Mhm.
or white noise. Those things can work. I know myself, I have to have my sleep music playing. And it's
Mhm.
interesting, my 11-year-old will frequently I'll go into her room and she'll have my sleep music track playing because she also needs that now.
Me too, right. But I could see it playing out like, if I'm playing with a kid and I know there's some certain sounds that they're working on, because I would say, we're working on, like being okay with the sound and giving them control of the volume and telling them we're going to keep it low, you have control over it, and we're going to play it in context with whatever we're playing. So if it's the fire truck that is stressful to them, maybe we're going to play with the cars and we're going to play city,
Oh, I see, yeah.
and then all of a sudden, oh, the fire truck's coming. Should we put the sound on so people know to move out of the way? And then if they have control over it, I'm wondering how something like that might work out when
I
they have control.
I love that. That is a fantastic idea, and I think that that is something that, I have seen in clinical practice. When the child is in control of making that sound, it's okay. When they are vacuuming, it's fine. When mom is
Right.
vacuuming, it is not. When mom's
Right.
using the blender, no, and so I've suggested to parents to, "Hey, why don't you make a smoothie together?" The child gets
Right.
to choose all the things that they want to put in, or maybe you're making ice cream, a special treat, and then they are operating that blender. So you're creating an exposure to it that isn't causing fear. And
Mhm.
you have to find ways to make it fun with kids. I think that's
Yeah.
always that's where you guys
Love
shine.
that. Well, and I love that whole idea of making the smoothie. Now you've got a reward built into it, right? Which, that's cool. And then the occupation of, making a meal and, there's just so much going on there that would be really fun. So, lots of cool things to have fun with. So I just see so many opportunities here and it makes me want to run down to the clinic and work with some kids. It just sounds
Yeah.
fun. Because I can just see this being, we talk about this whole year we've devoted all of our episodes to the neurodiverse community and population. And I just think there's so many of these things that can be life altering. So it's really, really exciting to think about that. So what I really want to talk about, before we wrap up because we could go on forever with this is we've talked about making helping the families understand, helping the kid understand, professionally working interdisciplinary. There's a lot of education that needs to happen, so I hope everybody goes out and educates everyone. But I want to get from you, because you've been phenomenal, what are our top 3 actionable takeaways for therapists to put into practice for, maximum impact?
Yeah, sure. I think it's intentionally screen for auditory
Yeah.
concerns, right? This is something you should be thinking about. Do you see listening fatigue? Do they have trouble hearing in background noise? Are they struggling to follow multi step directions when you're working with them? Do they avoid certain sounds or triggers? Yeah.
Mhm.
Um, I don't think occupational therapists will have any trouble with this, but think functionally, right? Focus less on what is the label of what it is, but how are these challenging the child's participation both at home and at school? How is APD or decreased sound tolerance impacting their ability to regulate their emotions or their body? Or how is it impacting their listening effort? All of these things um, can be very helpful to the patient. And the last, we've talked about this the whole time, is collaboration. We really need to work together on these kids. As I said before, I am not great with the whole therapy side of things. I'm good with the diagnostic and, okay, here's the plan, here's what you're going to do, but I really need other professionals to help implement this and help provide the therapy. So making that referral out to the occupational therapist, the speech and language pathologist,
Mhm.
and even looping in psychologists because they're, especially in decreased sound
Mhm.
tolerance, there's a lot of psychology here that can be integrated. Yep.
Very
If
true.
there's an auditory based concern, refer them out to an audiologist. We can make sure there's not a hearing loss, that there's not an ear infection or something else going on. And then we can help provide that diagnosis so that you kind of have an idea where to go with your treatments.
Right. So, last but not least, we have a little bit of time. What do you think is the next frontier in pediatric therapy in this area that our listeners should be on the lookout for?
I think what we're seeing right now is a better understanding of how the brain processes auditory and sensory information,
Mhm.
right? And as we improve this knowledge of how the brain is processing, it's really going to help inform and validate our intervention approaches so that we can really get at, okay, this is what we need to do to help this child. Um, we're really moving into that next era of really personalized patient-centered care where we're looking at, what we know about the brain from functional MRIs, what from EEGs, genetics, right? I've read some articles recently
Mhm.
on, we can look at genetics to see if somebody might be better able to tolerate different types of antidepressants, right? So we're learning so
Mhm.
much more about our brains and our bodies. And I think we can use that to really tailor our therapy and our interventions to help support our patients.
Yeah. Oh, I love that. That's a great way to end. So, on that note, I just want to say to everybody, if you're an OT, OTA, you're an SLP, you need to get a pediatric audiologist in your life. I was lucky to have Dr. Wakefield help me out when I was practicing in the clinic, and I recommend it to everyone. On that note, that's all the time that we have for today. And I want to thank Sarah again for her insight and all the clinical takeaways related to auditory processing and decreased sound tolerance. Thank you, Sarah.
Thank you. Thank you so much for having me. I really enjoyed it.
Thank you for tuning in to this episode of Pediatric Pioneers by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and complete the quiz for this episode. Pediatric Pioneers also listens to you. If there's a particular practitioner that you'd like to hear from, or if you have a question or challenge that you'd like to explore on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.